Okay, recording has begun. Welcome everybody to our Maine Rural Healthcare Education Grand Rounds. We're just thrilled to have everybody here, and we are thrilled to welcome Dr. Stetzer from the Albany Medical College. She'll be presenting to us today, recognizing and supporting neurodivergent traits in medical learners. And I just will take a moment to talk a little bit about her background, and I'm going to hand the floor over. I will ask, we'll keep our cameras off with the exception of Dr. Stetzer while she presents. And then when her presentation is over, we go into Q&A. I'm going to encourage everyone to turn your cameras back on so we can have a nice conversation and Q&A session when it's all said and done. So Dr. Becky Stetzer, she is an associate professor of family medicine, internal medicine, and neurology, and a fellowship-trained geriatrician with a special interest in cognitive impairment. She earned her medical degree from Emory University, completed residency at the Atlanta Medical Center, family medicine residency program, and geriatric fellowship at Tufts Bay State Medical Center. Clinically, she works at the Center for Excellence for Alzheimer's Disease, Albany Medical Center, where she provides care to older adults with cognitive impairment together with an inter and multidisciplinary team while hosting a variety of learners. In medical education, she serves as Assistant Dean for Competency-Based Assessment, for which she supports struggling learners. Wonderful background. Dr. Stetzer, welcome. Great to have you here, and the floor is yours.
Great. Thank you so much. All right, so I'll start by sharing my screen here. Okay, and then I'll go through your CME slides here. This has the activity code and the number to text to. I'll give you a minute to get that down, and then I'll come back to it at the end if anybody misses it. And then this is information about accreditation. And just in terms of disclosure, I sadly have none. And then this was information about the mobile app. So I can easily come back to these slides at the end for anybody who needs them. Okay, so just to talk a little bit about what I'm going to be going over, as mentioned, my medical education role, I work with struggling learners, and I've been in this role for about 3 years. And previous to that, sort of got here because of my interest in helping initially residents who were needing a little bit more help. As I was going through this role and working with more and more learners, especially graduate medical learners, I continued to have referrals that really were folks who were having non-specific difficulties in performance. And as we were looking to uncover roadblocks, neurodiversity kept appearing. And so it's really been a learning journey for myself. And as I've learned more and tried to start talking about this a little bit first at my own institution and then beyond, it seems like it's really resonating with people. And really, as everybody's trying to help our learners do the best they can and each other as well, I think it's helpful to be able to step back and recognize some of these different traits. When I'm working with learners, I really use the term, neurodivergent traits because, many presentations are a syndrome. Thinking with my geriatrics hat, right? We get a lot of syndromes, not necessarily a diagnosis. So I've got somebody with impulsivity. It may be from ADHD, but it could be another underlying cause. The other thing is that learners might have a diagnosis, but they might not, and they might or may not be self-aware of neurodivergence or neurodivergent traits. And so, I really don't need to have a diagnosis to be able to support them. But I found for myself in forming interventions, it's helpful to me if I can recognize some of what is going on because it helps me access different tools. And really, as we talk about the autism spectrum, I really believe we're all on a spectrum of neurodiversity, right? And there are different traits that we all have. And so it can be a lot easier to access accommodations if I'm not trying to stick to diagnoses or rules. So today I really want to share what I've learned about neurodiversity as it pertains to medical learners, both the positive and the negative, and some ways that we can do the best to teach all of our students. And it's interesting, every time I put this talk together, I change it a little bit because I've learned something new. So I'll get going. All right. So first, just talking about some terms. One is in terms of neurodiversity versus neurodivergent. So a neurodivergent is referring to an individual, whereas neurodiversity would be a group of people with perhaps various types of neurodivergence or neurotypical. And then for some, they like person first language versus identity first language. And there's, differences in debate among, people and professions. So really, it just sort of comes down to asking the individual to what they prefer, right? So, a doctor with autism versus an autistic doctor, and it's really can be different. When I'm talking about neurodiversity, sort of the most commonly recognized forms will be attention deficit and or attention deficit and hyperactivity disorders, autism spectrum disorders, and dyslexia and dyspraxia. There are some others that, depending on where you're looking, are included, but these are sort of the core. And what I'm really referring to today would be the ADHD and autism spectrum. The dyslexia and dyspraxia certainly can show up. It tends to be before people get to the clinical years, but not only. And the reason to be talking about this is that the prevalence of neurodiversity is increasing. Certainly diagnosis in childhood of both autism and ADHD, partly just due to increased awareness and some broadening of definitions, as well as increased recognition for both. In girls, it tended to be less well recognized because of different ways of presenting. And there's also a lot more discussion about it. And it was really interesting. There was a survey that I'd seen done from last year where over half of Gen Z identify as definitely or somewhat neurodiverse, which is really amazing when you think about that. And it just sort of speaks to this being a much more common topic and recognition of different ways of thinking, which I think is really, really positive. And then when we're looking at doctors or learners with neurodivergence, many are undiagnosed and or undisclosed, right? And so we might be working with some people who are diagnosed and we know about because they've shared it, but there'll be many others who are not. And some of that is just under recognition, right, by self or others. And then a large part of that is ongoing fear of discrimination. And there was an interesting study out of the UK a couple years ago looking at doctors with Asperger's, as it used to be termed for people who are on the milder part of the autism spectrum. But it was a qualitative study and looking at the impact of the diagnosis of having being on the autism spectrum. And it was really viewed as a double-edged sword, right? So some people really felt that it allowed the development of insight into difficulties and understanding of the challenges in the workplace, but also created a potential for prejudice and naming. So that's part of the challenge with working with this, that's still there, right? That perception of prejudice and the existence of prejudice. So when working with learners on this and considering entering into considerations of diagnosis, it's another aspect we need to think about. All right. So just for some definitions, right? So looking at adult ADHD, and I've got some of the DSM-5 criteria there that we would be thinking about. One of the ways I really like to be thinking about this is a different thinking disposition. And that idea for folks with ADHD, that cognitive dynamism, right? So that group of divergent thinking, hyperfocus, creativity, curiosity, right? And that that can be both positive and negative, right? So on the positive side, really having folks that may be thinking of rare differential diagnoses, hyper-focusing on symptoms, what might be less obviously related to the diagnosis, so, maybe skin signs of systemic disease, right? So it can be really helpful. For our earlier learners, limited experience might lead to hyper-focusing on something that's irrelevant, heading them down to the rare path, right? So there can be negatives to that too. And another thing cited for positive traits for ADHD among people who have it is really that feeling of courage, right? Being able to overcome some of the negative aspects of the diagnosis. So that can translate to strengths as well. In terms of the autism spectrum disorder, it's the DSM-5 says it described as a developmental disorder because it was really felt that the symptoms generally appear in the first 2 years of life. Of course, with more awareness of less severe phenotypes, they're identified later in life. And as I've entered in some of this space of learning more about it, there's actually quite a number of podcasts about adults who are newly diagnosed in their 40s, 50s, 60s. So really that increasing awareness. The classic symptoms of autism in children are not always present in adults on the spectrum, especially those that are underdiagnosed as children. But frequently what we'll see are some difficulties with communication, so nonverbal communication, social and emotional reciprocity, so that nonverbal skills or perhaps monologuing about interests, abnormal prosody with their speech, repetitive behaviors, sensitivities to different sensory aspects, so light, sound, temperature, even specific clothing. I can think of one of the learners that I worked with that was referred to as odd because they refused to wear scrubs in the ED and would wear a jacket, right? So those sensory issues that were coming out with her in that way. And then some executive functioning challenges. And then frequently with autism spectrum, there's another co-occurring addition, such as ADHD, which is referred to ADHD, right? Anxiety or depression. And in terms of looking at this, both this and the ADHD definitions are really based on a deficit model. And there's a lot more discussion now, especially in the autism education sphere challenging this, as it directs us to focus our efforts on trying to fix what autistic individuals can't do instead of building out from what they can. And many autistic people, see many of their disabilities as not so much inherent to being autistic, but rather that it's created by the social context of living in a society that's not designed for them, right? So looking, as I'm looking at my learners and working with them, really trying to think about where the strengths are and leaning into those and figuring out, even as we're thinking about this at a strengths-based model, that there are still going to be some areas of disability that need to be supported and how to distinguish with those. So this was an interesting paper that came out last year looking at self-identified strengths and challenges of medical students with autism. And, really looking at trying to find those strengths and lean into them, as well as accepting some of the unmet needs with support. And one of the terms that they sort of pulled together was intensely focused perfectionists, right? So that attention to detail, excellent recall, responsiveness to structure, that passion for a topic that can lead to expertise in a narrow field, and which all can be really positive in medicine, right? With the emotional aspect, either emotional detachment or high degrees of empathy. And then lots of creative problem solving, really thinking of them as innovative and concrete, which can be so useful, right? And so the challenges that came up were areas of where we could be focusing on adding some extra help, but really looking at the positives and really, again, trying to lean into those strengths. So these workplace challenges, right, are going to come up in a number of different ways. And I found this poster here by somebody who's an ADHD adult coach. And, looking at that non-ADHD storytelling, which is really what we're looking for in our patient presentations, right? Nice and clear. And when you look at the lower part of it, that presentation that we've probably all heard and perhaps given, right? These presentations that go all over the place. But if your brain is having ADHD wiring, presentations and problem representations are going to be even harder, right? This can also affect OSCE performance. This can be an issue, some for ADHD trying to get those thoughts down in a coherent manner in a time restriction. For autism spectrum, there can be difficulty suspending belief for interactions with standardized patients. And so with difficulty coming up with differentials because you've got some incongruent information. And then challenges discussed with both of these can make identification of hidden curricula even more challenging than for the rest of us. Professionalism concerns frequently come up. Some of the interactions with colleagues or organizational hierarchy can be challenged. Some, neurotypical social conventions and nuances can be opaque, especially to those on the autism spectrum, and an inability to recognize or interpret nonverbal communication. Challenges with executive functioning, which I'll get into a little bit more. And then the increased burnout, really going with this increased sensory and cognitive workload, right? So if there's overstimulation with noise and bright light, as well as the increased load of camouflaging. I mean, the camouflaging or masking, which is really taking measures to present in a manner that's consistent with the dominant culture, right? So for these purposes, talking about presenting in a neurotypical way, but then when you get into intersectionality, if you're working on gender normative presentations or a white Christian, cultures, or depending on where you are, the more layers of that is that much more of that cognitive load that is all happening along with the learning, right? So just getting into a little bit more about what's going on with these various aspects. This is one of those slides that I updated as I learned more, initially talking about the theory of mind blindness or theory of mind, where
move those boxes down here. We're really relocating.
I'm sorry, I'm not sure.
I think Annie's mic just went off of mute for a moment there, but I think we're good now.
Okay.
Thank you.
Okay. And so in terms of thinking about that theory of mind, where it was posited that there's an inability to create hypotheses about others' thoughts and emotions due to difficulty in reading nonverbal language, as well as having lack of awareness of nonverbal signals, creating unintentional communication. And really, like, thinking about that further, that it's really a misunderstanding between different neurotypes, right? Because we can have that difficulty for neurotypical people having difficulty understanding what is happening in the mind of somebody who's neurodivergent, what they're thinking or trying to display. And so this has come up with this first starting about the double empathy problem, which is where you've got a breakdown in communication between somebody who's neurodivergent and neurotypical. And then, whoops, that went too fast. And then the next is looking here at the empathy problem that that can come up with the cultural divide, right? So when we have students coming into the culture of medicine, they're learning that whole new culture, right? As well as with patients, right? So much of what we work on with our learners after they learn all the medical technology is how to translate that back into lay terms. So either as the patient or the learner. And so then when you've got both of those things going on. So we're talking about that from that double empathy to triple empathy when you add in a learner. So if you've got an autistic learner navigating both communication challenges with teachers and with patients, along with the cultural divide, there can be a lot going on and a lot of opportunity for misunderstanding. Executive functioning skills is another common challenge with neurodivergence. The first, sort of thinking about cognitive flexibility or shifting, having different, rules of what applies and being able to modify rules as appropriate. Updating working memory, right? So if you've got a decreased working memory, holding the history gathered in your mind as you're doing in the interview, integrating new information, adjusting your questioning and differential. If you have trouble updating that working memory, it's going to be easier to fall into premature closure. So we may see that. Initiating, planning, prioritizing, organizing, carrying out tasks. That's what we typically think of as the executive functioning. And then the inhibition of overwhelm, right? So frequently we may see those impaired internal feedback loops of self-perception and self-regulation. So it can really overwhelm one's ability to manage emotion. So when all of this is going on, really having that overwhelm, which can really stop somebody in their tracks. So then when putting this all together, what are we going to see then when we have a learner and that we might want to be thinking that they have neurodivergent patterns or challenges? And I really got that asterisk there because, again, just thinking about this in terms of neurodivergent traits, which may lead to diagnosis or consideration of a diagnosis, but it may actually just be a presentation of something else going on. So again, having these start to open questions instead of closing them. But so thinking in terms of plateau or worsening performance, I see this a lot, the referrals that come in with changes in context or increasing responsibility. So beginning of second or third year of residency. Vague problems with professionalism or communication, especially when there are interactions that are problematic and, the context, the tone, or that might be coming across as disrespectful. Inconsistent performance. So knowledge may be, patchy at places, maybe premature closure. Some limits of insight, so clinical overconfidence or underconfidence, not anticipating consequences of decisions, leading into judgment errors or prioritization errors, thinking about, I had one learner who was so good at doing a deep dive into a patient's history and finding old charts, but wasn't able to prioritize when to do that and when to put that to the side to attend to other new admissions, right? And then, as I mentioned before, difficulty with transitions, having those new social relationships at the beginning of new rotations and making those first impressions. So I had the opportunity, there's the Center for Research in Autism and Education has a yearly lecture, and there was a presentation from 2022 that was available online, and I recommend it to anybody who's interested, by Sue Fletcher Watson, who really talked a lot about neurodiversity affirming education and what can we do to create that space. And so I pulled out some of those looking at in terms of the medical education, right? So thinking about expecting diversity, adjusting from the paradigm that neurodivergence is the exception, requiring specialists or extra resources, instead having a goal of individualizing learning for all students, which I think we're all moving towards anyways. Really having that learner-centered teaching and coming back to recognizing the neurodivergent traits rather than relying on learners to disclose their neurodivergence, and really recognizing that not everyone who needs support has a diagnosis or a neat box. So being able to recognize these challenges is enough for us to lean in to take action. Development of self-assessment and self-advocacy skills. Self-assessment skills is really one of my passions that I work with medical students, is really being able to develop that skill and figuring out where you are, what your learning needs are, and how to help your teachers give those to you, right? Some students have their learning needs met by the standard educational program, but not all of us, right? And so we all need to be able to identify where we need that as students and as lifelong learners, right? Something I need to continue doing as I practice. And then that recognition of strength and diversity. So challenging the tacit assumptions of medical culture and looking at the professionalism. What are the standards that we have now that need to be upheld to reflect, respect, optimize patient care and functioning with the medical system? And what standards cause pressure to conform that leads to masking, shame, fear of being discovered as neurodivergent or anything that's not part of the Maine culture, right? And then thinking a lot about excellence and how we define that. As I think about, as I also serve as an advising dean, so help to put together those dean's letters for graduating medical students. And the easy applications are those that include, high scores and leadership positions and publications, and learners don't really want to be showing their weaknesses. But I really think about how much this misses those students who didn't thrive in the standard pathway, but have demonstrated, master adaptive learning characteristics of curiosity and motivation, that they've had a growth mindset and a resilience to adapt to all of these things. And wouldn't that be great if that's what we were highlighting a little bit more? Because those are the residents we want, right? Who are able to do all of those things. So that's sort of a bigger picture type of thing. But I think the more that we're all thinking about that, the more that we can help move our medical culture and medical education culture in that way. So I wanted to share this autistic space model. Mary Doherty is actually the founder of Autistic Doctors International, and does a lot of work both in supporting autistic doctors as well as promoting a better health care for people with autism. And this autistic space that she has proposed has really been about how to care for our patients with autism, but I really found it well suited to considering how we can accommodate learners with neurodivergent traits, not just autism, and honestly, really will create a better learning environment for all of our students. And I feel like this is a particularly great framework to sort of lean back into and to think about when you recognize a learner that's struggling. And what this does is it's got your acronym of sensory, predictability, acceptance, communication, and empathy. And thinking about all of those things within physical space. So thinking about the physical environment, including sensory issues and spaces for restorative solitude, processing space, so giving that extra time for processing during verbal assessments, asking one clear question at a time. And then that emotional space, understanding differences in emotional regulation, right? And not trying to force learners out of moments of shutdown, perhaps during stressful exams or stressful moments. So just to delve into this a little bit more, so thinking about the sensory, right? That sensory stress can really reduce that ability to learn and communicate. Thinking about the visual, auditory, olfactory, tactile, and temperature sensitivities, right? So like I had one learner with both autism and ADHD who was working in the emergency room, and they were able to set up a space that was low sensory stimulation. So when they needed a break, they could go and do that and do a little self-regulating. But I even think about that in terms of teaching, right? So like when we've got these big teaching teams on the wards and having conversations like at the nurse's station, there's a lot going on there. So if you have attentional difficulties, you're probably not going to pick any of that up. So, and that's not the best practice anyways, right? We should be going into a quiet room and not having patient discussions there. So, really being focused on being aware of that. Thinking about predictability. So as much as possible, giving unambiguous information about timetables and rotations and being clear and consistent with expectations. At times, that can be that hidden curriculum where it expects students to know what to do or what we want, and being as explicit as possible. With acceptance, as I mentioned before, reevaluating those definitions of professionalism. And thinking also in terms of those, like when things don't go right, when there's non-completion of assignments, doesn't necessarily mean defiance or not caring about things, but instead just sort of thinking about it from a different framework. Do we need some more explanation about why these things need to be done? One of the things I've noticed with some of my ADHD learners is, they've got some pushback when they feel like they don't understand, they don't see the point of doing something. And sometimes I feel like I could learn from that. Some of those hoops we need to jump through, do we really need to? But when we're able to look at, like certain tasks that need to get done, going back to the reasoning of why it is important to them, how can we get to their own internal motivation to getting those things done instead of just doing it because it's supposed to be done. For communication, really being explicit with directions. And this is interesting. This is where I really find that the two can be different. So, for our autistic spectrum individuals, being very clear, right? Not having mixed messages and being very direct, sometimes to the point that it feels rude. Whereas for our folks with ADHD, they may be more sensitive to rejection and so need a little bit more of a gentle message, or one that's really clear that it's not an overall judgment, but just looking at a specific incident. And then also really thinking a lot in terms of management reasoning, getting into the specifics of that, because a management practicalities are going to involve both executive functioning, right? So systems management, as well as social cognition and perspective taking. So that can be a really difficult task for some neurodivergent individuals. So really trying to break that down, because sometimes that's where things seem to break down, or we can be more vague in terms of how to make things happen. And then just with empathy, right? So really having empathy for emotional and cognitive fatigue. I think about my energy capacity edge when I'm in my outpatient limit doing a cognitive evaluation, with a new learner in the room, where I'm trying to gather history from the patient and the caregiver, attending to who's giving the history, the degree of normalization from the caregiver, the nonverbal communication of support needs while observing and diagnosing my learner, right? There's a lot going on. And then I think about, gosh, if in addition to that, I was also trying to translate from a neurodivergent framework to a neurotypical one, you can see where there can just that breakdown can start to be there, or you can start to miss things. I recently just came across this article from a magazine of psychiatric trainees committee from the Royal College of Psychiatrists in England. And, this was a framework put together by one of the residents with ADHD of ways to have support for ADHD learners. So they've got a coffee as the framework for this, but in many ways, there are a lot of things that overlap with that autistic space. But really, in terms of talking about curiosity, not criticism, trying to understand an individual's needs, looking at the outcome, right? Allowing space for different approaches to completing the work, and understand the process might need to accommodate sensory or learning needs. Having flexibility when possible with hours and timetables, hybrid schedules if possible. For feedback, really thinking about, again, that curiosity of what your learner needs. Does it need to be really clear and direct? Is it somebody with ADHD that's maybe struggling with a rejection-sensitive dysphoria, and we need to have a different kind of framework? Thinking about exams if accommodations are needed. Likely you'll need formal diagnosis and it's going to take time. So really initiating that process as early as possible. And then that extra processing time just as with that space mnemonic. So just trying to pull this all together, because there's sort of a lot of different parts of this, but when to think about recognizing that your struggling learner might be having neurodivergent traits, thinking about performance problems, right? So somebody has plateaued or worsening or inconsistent performance. When you find yourself saying or hearing from faculty, I just don't get it, or are they lazy, or do they just need to work harder, right? That those might be some clues, because everybody who is a medical learner has worked really hard to get here, so probably is not lazy, right? Looking at patterns, or can you identify a pattern that something's always coming on at a point of transition, specific environments, increase in responsibility? If there are concerns about judgment, especially if it seems like there are patterns that are rigid, that they are able to apply the rules, but they need to learn the rule for each specific situation, they're trouble generalizing it or modifying. And then remembering for ourselves to avoid premature closure, right? So thinking about, well, that's coming across as possibly a neurodivergent trait. Is it that, or could it be a mental health issue? Could it be a trauma history? Could it be substance abuse? Learning challenges that are just now reaching the limits of prior compensatory mechanisms, right? So again, having the recognition of these traits being the beginning of the questioning. And then some ways to, support neurodivergent traits, whether or not there's a diagnosis, whether or not it's recognized or unrecognized by the individual. And so really trying to lean into the strengths, having that strengths-based approach while still recognizing the need for support, being clear with communication and adjusting to communication styles, trying to provide that physical, sensory, and processing space, and thinking about that when we've got somebody. And then, perhaps thinking aspirationally, but really being intentional about what we want to perpetuate in our medical culture, and how in supporting those different from us, we're also supporting neurodiversity as part of overall diversity, and really trying to create that optimal space for all of us to learn and care for patients. So I'll end there and move to questions and discussions. I do have a few slides of references, so if you're interested in learning more, I'm really happy to share those.
And I invite folks to turn your cameras on for the Q&A session. It's a community of folks here, and I really look forward, and thank you, Dr. Stetzer, that just outstanding presentation. I look forward to hearing questions and answers. Thank you.
Right.
I said, Tom, go ahead.
All right. Thank you very much. It was a really very helpful talk and really interesting. My question is about how you counsel, I guess, the learners on communicating their traits to their faculty, if you do at all. There's different ways that we interact with learners. Some are very short encounters, like inpatient teaching, and there are some other where they're longitudinal, like a continuity clinic. So, do you counsel your learners to talk about it with their preceptors, and if yes, how so?
Yeah, so it's really learner dependent, and I have the luxury of, when I'm working with learners, to have some time to sort of get into the conversations with them. And those who are receptive to having a conversation, right? That's where it kind of breaks down, is what I'll talk to them about is in terms of advocating for their needs. So I don't necessarily advocate disclosing diagnoses, and I don't even push that. Sometimes I will offer the option or consideration of neuropsych testing to allow for more insight. But, I'll say to them, like, if it's really helpful if something is summarized, or you need something written down on paper, to ask for that, right? And I have one like who's a resident who's in his third year now and leading teams and really struggling with staying on top of tasks. He says sometimes the attendings get annoyed because I want to run the list before we break off. And I was like, okay, well, maybe it's okay for them to be annoyed and just let them know for me to take the best care of the patients, it's really important that we go over these on my list. Can we take a minute to do that? And so the more self-awareness they have in communicating what they need specifically rather than even where they're coming from.
I'll throw a question out there.
Mhm.
One thing you mentioned was you were talking about giving feedback at the nurse's station. Maybe that's not the best idea anyway, like for any type of learner. In my experience of thinking about accessibility for learners outside of medicine, what we found was that when we made adjustments for our neurodivergent learners, our neurotypical learners actually appreciated those changes. So my question is, in your experience and changes that you've made operationally, are there other ways that you found the wide learner base all appreciated the update when you focus on supporting neurodivergent learners?
Yeah, for sure. And it's funny because like even looking at the autistic space, framework, like we all want all of that, right? And so, and I think about, one, certainly just the space that we're teaching in. I mean, we all know it's not best to be talking about patient care in busy environments. We should be finding the room. So doing something like that. But I found the other big one is really breaking down some of the nonverbal communication, right? So you think about like at the bedside or even, I mean, in the space that I operate in working with dementia patients and caregivers, there's a lot of nonverbal communication going on there because we don't want to say everything explicitly. So coming out of the room and saying specifically like, hey, did you notice when, like the caregiver made eye contact with me? Or did you notice that closing of the body language, right? And even that comes up with, diagnoses, a patient who came in who was complaining of having these increasing panic attacks and shortness of breath. And, the whole time you're saying, I think it's because I just went on this trip and kept like rubbing her calf, right? And lo and behold, she had a DVT, right? But it was really saying like, that wasn't her typical behavior, did we? And so stepping out of the room and talking about those small observations that it can be easy to not do that. So.
Nice.
I have one other question. What advice or what strategies would you suggest for providing feedback to a resident in a situation where there has been a misunderstanding between someone who is on the neurodivergent spectrum and someone who is not, particularly on an interdisciplinary team is what I'm referring to, where a neurodivergent trait may unintentionally provide or leave a member of the team feeling, so in this example, feeling uncomfortable by a lack of spatial awareness or a lack of social cues that the conversation is over. And the neurodivergent resident is standing there in front of an individual for a prolonged period of time. And this has often led to the impact of making others in the team feel uncomfortable. How would you recommend providing feedback to a learner in that kind of a situation?
It would be helpful if the learner were self-aware. I don't know if they know that they are, but I think that it comes down to that really clear communication and having somebody say, one, the conversation is over. Okay, I need to go do my work now. And just ending it or just saying, I'm somebody who needs some personal space. I feel uncomfortable when you stand that close to me. And I always bring that, that I statement and I feel so that you can bring it back that way. But again, just being crystal clear You can still be kind when being clear, but a lot of times with those, when you try to say something subtly or, indicate that, it's just going to be missed. So, yeah.
Sounds like there's coaching of not just the individual, but the whole team on how we communicate.
Absolutely. And I feel like that's a big part of this. I know it's something I'm trying to do within, my own institution and just sort of talking about this more, but how we approach our conversations and kind of hold space for each other if you see those behaviors that are not maybe what you're hoping for.
Jim.
You could always mention the close talker episode of Seinfeld.
Although I find some of my younger learners that they're missing it, that definitely makes me feel old.
Yeah, I was going to just kind of piggyback on what you just said there. I think for many of us in medical education, we don't work for the university and for the institution of higher learning that's sending us learners. But I think it's a good message for us both to kind of talk about, one, having the learner advocate for themselves in a way that makes, doesn't undermine who they are, but also gets them what they need. And for us to have communication about, well, how best can we help this individual, or how best can we help the group? I think, I've tried to do that, if somebody has either self-identified or we have identified an issue there, taking the chief resident aside, so to speak, and just saying, hey, listen, I want you to know this intern would do better if you do some more visual discussions. This intern would do better if you allow them a little bit more latitude in their presentation. And so I think those kind of things, just help the entire team, the care team as well. I also agree. Discussing things in front of the nurse's station is distracting for everybody.
Distracting. And I think I agree completely. Like if you recognize that, helping to coach team members as well as trying to model it, and I know I'm terrible with names, and I've really tried to have with learners say, when they come in, can I see your badge? I'm a visual learner. Right. And saying that's how I'm going to learn best. And if I ask you again, it's not because I'm not paying attention, but sometimes I need it 2 or 3 times. So even trying to this is my area of where I need some accommodation, hoping that will encourage that for them as well and help me learn their names.
Folks, I encourage more questions. I am just going to drop in the chat for those that didn't see it, some of the CME information. Let me see if it goes through. It's really big in the chat. But it's there. This is what Dr. Stetzer shared at the beginning. And I know she has a slide, but she'll share at the very end here. So continue to ask questions, but for those of you that need to put that text through, it's there in the chat for you.
You want me to put that slide back up? I can do that.
Yeah, it couldn't hurt if you want to just drop it on the screen for folks. But again, that's not to say stop asking questions. I know we're a little bit past time, but I do not want to cut anybody off if they're interested while we have Dr. Stetzer here. Good. Well, folks, were there any last questions? Dina, I saw you talking, but your mic's on mute. Not sure if you're asking. Okay, very good. Awesome. No, great to see folks in the chat there putting some comments in. The last thing I'm going to share is that next month, I'm really excited to have Tom Guerin present. Tom was in our meeting today. He is a rural GME director with the Merge Collaborative. He's a former program director, now associate DIO at Maine Medical Center, and he'll be presenting on difficult conversations with learners. And so a really, really timely one presentation into the next, right? We have neurodivergent learners, and how do you have that difficult conversation when they do arise for any learner that comes through? So we do hope folks will join us always on the second Friday at noon. It's the exact same link that got us here today. So Dr. Stetzer, again, thank you so much for presenting today. Big claps all around. Really, really grateful for your time and expertise. As always, this has been recorded and it's going to be posted on the Merge website. We actually now have a link at the top that says Grand Rounds. You can find all of our archives there. So we hope folks use that as a great resource, and we look forward to seeing you at our next presentation.
Thanks so much.
Thanks, everybody.